right, good evening, Chairman Hayden, committee members. Thank you for the opportunity to speak today. My name is Denise Stuit. I'm a certified registered nurse anesthetist in Missouri, and I'm here today to represent the Missouri Association of Nurse Anesthetists. The heart of this bill is to update laws to benefit both metropolitan and rural constituents. So we are in support of this non-appropriated bill because it provides direct benefits to all Missourians. There are currently over 1,700 CRNAs in the state of Missouri, and we practice in all hospitals with surgical services. We are the only anesthesia provider in 41% of hospitals, and the only anesthesia provider in 78% of rural hospitals. In 43 states and in all branches of the U.S. military, CRNAs are practicing without supervision. Yet Missouri statutes can currently say that CRNAs are required to be supervised by a physician, a dentist, or a podiatrist. These operating providers want to focus on the surgery and not be burdened with the presumed liability of managing over a specialty that they themselves admit they were not trained in. This implied liability discourages partnership with the CRNAs and reduces recruitment to these rural hospitals. CRNAs and physician anesthesiologists are two different types of anesthesia providers with different backgrounds. CRNAs, we are not trying to diminish the value that anesthesiologists bring to Missouri. We both are valued members, and we both are very much needed in the state. House Bill 329 seeks to remove the word supervision and allow CRNAs to practice at the request of a physician, dentist, or podiatrist. As such, this legislation does not remove physician involvement from the operating room. Furthermore, the bill fixes a misinterpretation that Missouri CRNAs are prohibited from giving controlled substances. This would include pain and anxiety medicine to patients without having first have an order or a protocol. Interpretations of the statute are inconsistent, and CRNAs are left in jeopardy for the potential violation of a regulatory interpretation. House Bill 329 is a budget-neutral solution to help alleviate these concerns without compromising patient safety, and updates current laws to more accurately describe how CRNAs practice today. Despite what others may say, anesthesia is exactly the same no matter who is administering it. We all use the same machines, the same medications, and there's multiple publications to confirm that there is no difference in safety if there's a CRNA at the head of the bed or a physician anesthesiologist. We are two separate anesthesia providers that have overlapping scopes. This creates competition, and we encourage competition. It's healthy for healthcare reform and to keep costs low. Either way, we share the same standards of care. We use the same guidelines, the same protocols, all for the best interest of the patient. Both physician anesthesiologists and CRNAs have a longstanding history of providing patient-centered care, though let us not forget that the CRNAs are the ones providing the anesthesia. We ask that you support House Bill 329. It clarifies the statutes for practices already in place, removes the regulatory burdens for CRNAs and the healthcare facilities that are currently suffocating in rural Missouri. It allows CRNAs to practice without the risk of violating contradictory regulations. It's a step in the right direction to ensure that Missourians have adequate access to care. For these reasons, we respectfully ask for your support for House Bill 329.
Questions? I guess I have one. Under the bill, it would allow for pain management clinics operated by CRNAs. Is that correct?
Oh, that's a good clarification. So we made sure in the bill to say that anesthesia services can only be provided after the request of a physician, dentist, or podiatrist.
So you cannot operate an independent pain management system under this bill under your interpretation?
No, sir.
Okay, thank you. Representative Keithley?
Thank you. To inquire.
Go ahead.
I think to me the major or the significant change to the statute in this is removing the supervision of an anesthesiologist or a physician, a dentist, or a podiatrist, and that's what I guess is the freeing part that allows CRNAs. I don't know if that's what you mean when you say this is a clarification of practices that are what's already in practice. But I mean, to me, I read that and I read it as pretty broad because it doesn't require an anesthesiologist. I mean, it requires a physician, a dentist, or a podiatrist. And I'm wondering, I'm assuming that CRNAs are practicing in a surgical setting predominantly, and I'm wondering what kind of procedure treatment is going to be administered where there would not be a physician, dentist, podiatrist, or anesthesiologist on call. What is the situation that this statute allows a CRNA to operate without a physician in the room?
Absolutely. So the state map that was passed out with the green counties, those are currently counties that only have CRNAs. Those counties do not have physician anesthesiologists. So in those counties, the supervising provider is the surgeon, the dentist, or podiatrist. We call these the operating practitioner. These operating practitioners do not wish to supervise the anesthesia. They were not trained in the anesthesia. We have some testifying here today to provide witness to that. And supporting states, as Representative Cook presented, that all of the surrounding states around Missouri do not have a supervision requirement for CRNAs. So we were trained as independent practitioners. And the misinterpretation is both for what the word supervision means, which implies that the surgeon, dentist, or podiatrist is overseeing what the CRNA is doing, and that is not accurate. In addition, that in our current state statutes, there was a little miscommunication with the Bureau who regulates narcotics to say that CRNAs could not administer controlled substances. Now, this is important because the definition of anesthesia itself is to abolish pain that is accompanied with surgical or procedure stimulus. So for a CRNA that we are having patients go to sleep for procedures and surgeries and treating their pain, you can't take away controlled substances and allow us to do our job. Missouri is the only state where CRNAs have this extra step to jump through to get controlled substances for our patients. And then lastly, to clarify, the medication for controlled substances, again, that's only during anesthesia services provided for a surgery procedure at the request of a physician, dentist, or podiatrist.
As it relates to the beginning part of that with the physician, so I mean, I'm hearing that the rationale for this is, well, physicians, dentists, podiatrists, if they're the ones performing the surgery or the procedure, well, they don't want to do the supervisional. But it's not changing the on the ground fact that there is always going to be a physician in the room overseeing what they're doing in the building, certainly when whatever's happening, because by definition of patients in surgery, there's someone performing the surgery, and that's not a CRNA presumably doing that.
Exactly.
And in which case, so just to finish is I see this as less actually changing any practice, true, which I think has been admitted, has been stated in your testimony, but I do see it as a significant sharking of liability. Is the main concern less about CRNAs in this and more about doctors and physicians who just don't want to be responsible for CRNA activities that maybe they admittedly don't know much about? But
yes, yeah, and I have a colleague here today that's going to talk specifically about the presumed liability and the liability that is put upon the surgeon, though that does not relate to case law. So case law shows that there is no difference in liability to a surgeon, dentist, podiatrist, again, no matter who is providing the anesthetic. But that word supervision makes it seem as though they should be responsible. And then also to clarify, so in hospitals this bill allows hospitals to choose their own supervision model. So we fully recognize that mainly in metropolitan areas, they will likely keep the same supervision that is depicted in the current statute. So this would just allow rural facilities and their medical boards, made up of physicians of their local region, it would allow them to decide what's best for our patient population.
thank you.
Representative Fogle.
Thank you. Can you quickly talk me through a lot of the conversations we've had today regarding the earlier bills was about education. So can you quickly walk me through the differences between what you guys do and what training perhaps a general dentist would have as it relates to administering anesthesia?
Yes, absolutely. So CRNA starts out with a bachelor's degree in nursing. It's a 4-year degree. Then we work as a nurse. We are required to work in an ICU for a minimum of 1 year, though the COA reports that the average before admittance is 4.5 years, working in an ICU. Then we are admitted into graduate school, which is a minimum of a 36-month program, after which we pass a national certification exam before we are allowed to practice. A dentist, I think, takes various rotations through certain things. It's actually funny, we had at the hospital that I work at, we train oral maxillary facial surgeons, so surgeons that do surgery on the face and the jaw. So they start out as dentists. They come to us and do a rotation with us in the OR for several months before they can go on to practice surgery. But just ironically thinking that I was training the dentist in anesthesia, and he, according to our current law, was allowed to give just like fentanyl, for example, and I was not. And I was educating him on the practice of anesthesia. Dentists in general have no specific training in the administration of anesthesia, similar to podiatrists as well.
Representative Thomas,
To inquire, please.
go ahead.
Thank you. A clarification. When you said earlier that you would not be able to operate a pain clinic, I want to know if that's accurate, because you said if there's a physician referral, you could provide the services. I don't know that there's anything in here that says you can't, under the new conditions, that you can't operate the clinic, which would be a change.
Yeah, so according to our current state statutes, we have to practice within our scope and our training. I was not trained in pain, so I would not be allowed to go open up a pain clinic. There is a fellowship that a CRNA can obtain. So after 2 years of being a CRNA, you go back for a 12-month fellowship in chronic pain management. There is another certification after the end of that training, and then you're certified to practice in chronic pain management. But again, if a CRNA is not trained in that, then that's not within their scope and would not be allowed within the statutes.
Okay, because again, that was unclear, since you said that as long as you had the referral, you could provide the treatment, and I'm still not sure that you can't operate that clinic. And are you able to do spinal stimulators?
So no, spinal cord stimulators are not taught extensively within the pain certification course. No, CRNAs would not be placing spinal cord stimulators. Even after the pain certification, those CRNAs would still need a patient to be a request from the physician, dentist, or podiatrist. So even though they're certified, they still have to have a request or a referral.
But once you have the request, can you then follow up on that?
For those that are pain certified, yes,
Right.
that is within
so
their
you
scope
can
and
provide
training.
that. Okay. All right. Thank you.
Further questions? If not, thank you very much, and thank you for your testimony.